All right, good morning everyone, and welcome to our first presentation for 2022. My name is Shavina. I'm one of the ENT registrars here at the University of Cape Town. It's 8 o'clock now, so I think we can start the meeting. So today we're going to be looking at auricular perichondritis. My disclosures are there's no conflict of interest, there's no intent for copyright infringement, and I did get verbal consent from the patient. The patient we have is a 54-year-old gentleman and 3-day history of progressive swelling and pain of the left outer ear. It was associated with fever and left-sided level 2B lymphadenopathy. The only significant previous history is that he had a stab to the left postauricular area on that side 5 years ago, and with a glass bottle, but there was no residual glass within the wound at the time of suturing. He is a known smoker and no other comorbidities, and was tested on that admission as RBD negative. Get this away. So on examination of this patient, you can see that he's got swelling and erythema of the helix, extending from the helix up until the lobule, with a maximal fluctuancy noted over the antetragal area. He also had preauricular and infraauricular swelling and marked tenderness. And then on neck examination, he had 2 small lymph nodes at the level of 2B. To note, his mastoid area was not tender or swollen. That little bit of swelling that you see there, that's secondary to his suture that he got 5 years ago, but there was no tenderness over that area. On examination of the ear canal, that was clear with no evidence of otitis externa, and the tympanic membrane was normal. The EC decided to do imaging because they were concerned about a mastoiditis on him, and these are axial views, and you can see that there's marked soft tissue swelling of the pinna and outer ear, and then there is a obvious collection there. Looking at the coronal views, I want to mention here, once again, there is a lot of soft tissue swelling, but to note that the underlying cartilage is normal, hence the diagnosis of auricular perichondritis. So the management of this patient, he was admitted to the ward. He received IV antibiotics. In total, he received 3 days of IV and 7 days of oral co-amoxiclav. He did receive a single dose of IV ceftriaxone at his base hospital before coming to us. An incision and drainage of that antetragal fluctuancy was done. It was done under local anesthetic, and a corrugated drain was left in the cavity, slept in for about 48 hours. We managed to aspirate about 3 mL of pus, which we sent off for MCNS and TB gene expert. The pus aspirate, the results were really not significant. No organisms were observed, and the TB gene expert, as well as the Ziehl-Neelsen stain, is negative for TB, and the cultures both on the aspirate as well as the pus swab that was done showed no growth after 2 days. Clinically, the patient's swelling and pain resolved after day 3, and the patient was discharged. Unfortunately, he never arrived for his follow-up date, so we're not sure about the overall outcome of this patient. So just looking at the auricular perichondritis, the talk I'm mainly going to focus on a differential diagnosis and some other conditions that we don't often think about that could mimic this, this presentation. So going into just to start off with, so auricular perichondritis is inflammation of the perichondral layer surrounding the cartilage of the ear. It classically presents as redness and painful swelling of the auricle and classically spares the lobule. The diagnosis is made on history and physical examination findings. Some distinguishing features is that for the differential of an expanding otitis externa or concomitant otitis media is to look within the ear canal to ensure that it's normal, and also to look at the tympanic membrane to see if it's normal. The most common organisms that are isolated from suppurative perichondritis is Pseudomonas. Although in the literature they have mentioned Staphylococcus aureus, E. coli, and Proteus species also being isolated. The etiology, the most common precipitating factor is penetrating trauma to the cartilaginous pinna, and more these days with patients having higher ear piercings. Transcartilaginous ear piercings are also becoming quite a significant risk factor. Less common factors are untreated middle ear infections, iatrogenic post-surgery, patients who are immunosuppressed or on immunosuppressive therapy, minor traumas such as patients who scratch their ears or go and have acupuncture, and then less commonly insect bites. But looking at the literature, there is a significant proportion of patients who actually don't have any identifiable precipitating factor. So the differential diagnosis for this condition is wide and varied, and could probably go on for days explaining each one. But I'm just going to highlight a few that I found interesting and some that we don't often think about. So we'll go through a few of them in this talk. The first one I want to have a look at is otitis externa. And otitis externa is inflammation that can either be infectious or non-infectious of the external auditory canal. In some cases, the inflammation can extend into the outer ear, such as the pinna and the tragus, as you can see in the photo on the right. And it is classified as acute, so symptoms that last less than 6 weeks, or chronic, so symptoms that last more than 3 months. The main way to diagnose these patients is clinically. So on otoscopy, you would look for erythema and edema within the ear canal. You'd also, if you are concerned about concomitant otitis media, you may also find erythema of the tympanic membrane with an associated middle ear effusion. Pruritus and ear pain is usually worse when you manipulate the tragus and the pinna, or manipulate both. And often, if it's not involving the outer ear, the ear pain is disproportionate to the physical examination. And this is due to the irritation of the periosteum just underneath the thin dermal layer of the bony ear canal. It can also present with otorrhea, oral fullness, and hearing loss. The most common organism isolated in this condition is Pseudomonas and Staph aureus as well. Although some papers have suggested that polymicrobial infection is more common, and then very rarely will get fungal infection either by Candida or Aspergillus. Just quick to mention, malignant or necrotizing otitis externa is something to think about when you're diagnosing a patient with otitis externa. This is a life-threatening condition that commonly occurs in immunocompromised patients or in older patients, specifically with diabetes. And essentially, it's an extension of the infection that can spread into the temporal bone, and it is also once again associated with Pseudomonas species. About 90% of cases isolate Pseudomonas. So early diagnosis is quite crucial in these patients because it can be a high mortality rate, and it should be suspected in patients with diabetes or immunocompromised patients who have otitis externa with ongoing fever and that are not responding to treatment. And the infection, like I said, can result in temporal bone osteomyelitis and can be associated with the cranial nerve palsy, specifically facial nerve. Other complications of malignant otitis externa to keep in mind are, like I said, cranial nerve palsies, meningitis, dual sinus thrombosis, and cranial abscesses. So looking at the general treatment for otitis externa, we often treat them topically with antibiotics. We can either use specific drops. You can use polymyxin B, neomycin, and hydrocortisone drops. You can use ofloxacin drops, or you can use ciprofloxacin with hydrocortisone drops. The American Academy of Otolaryngology has recommended that for acute otitis externa, oral toilet and cleansing of the external ear canal is recommended. And then there are only certain indications when you would look at using oral antibiotics. These are patients with diabetes or have increased morbidity, patients with HIV, patients with suspected malignant otitis externa, and patients with concomitant acute otitis media. Topical antifungal agents are not considered first-line treatment for these patients and are only reserved for patients where during otoscopy there is a high suspicion of fungal infection or if it is picked up on cultures. So then looking at herpes zoster, this is another condition that can mimic perichondritis. It is a painful, burning, blistering condition that occurs around the ear. Can extend onto the face, into the mouth, and on the tongue as well. And it's thought to be the reactivation of varicella zoster virus along the distribution of the sensory nerves innervating the ear. Specifically when it infects the facial nerve and the geniculate ganglion, there's a condition known as Ramsay Hunt syndrome, where these patients present with facial nerve palsy. These patients need prompt antiviral and corticosteroid treatment. Some other symptoms associated with herpes zoster are vertigo, nausea, vomiting. They can have hearing loss, hyperacusis, and tinnitus. And the mainstay of treatment is really early, so within 3 days of symptom onset, of corticosteroids, either prednisone or prednisolone, and antiviral therapy, either in the form of acyclovir or valacyclovir. Analgesia is important in these patients. They often have severe pain, so good analgesia is recommended, as well as putting patients on carbamazepine to help with neuropathic pain. Individuals with Ramsay Hunt syndrome often don't have incomplete eye closure, and special care needs to be taken to prevent corneal injury in these patients. So artificial tears and lubricating ointments can be prescribed to protect the cornea for these patients, and also eye patch at night. Another condition that, although rare, we have seen before is erysipelas. It is a acute bacterial infection of the dermis and hypodermis. So it's a superficial dermal infection, and it's associated with clinical inflammation, and it often involves the face and the ear. The symptoms include a high fever. It's often a well-demarcated diffuse erythematous and edematous rash. And when it involves the face and the ear, this clinical sign is known as Millian sign, and this helps distinguish clinically this condition from just general cellulitis of the face. Some of the important risk factors of these patients is that they often have some sort of breach in the skin. So patients who have fungal infections, especially interdigital, patients who have open ulcers, patients with chronic circulatory issues and venous and arterial circulation problems, and then like I said, chronic venous stasis ulcers predispose these patients. So you often see this condition usually in the lower legs and the ankles, but it has been described in the face as well. The treatment for these patients is penicillin, and it's usually benzophine penicillin or penicillin B. If patients are penicillin sensitive, then clindamycin can also be prescribed for these patients, and the duration of treatment is usually 10 to 14 days. You can also use a first-generation cephalosporin for these patients, like a cefalexin. It's important to follow up these patients because there can be recurrent episodes that can result in cartilage damage, specifically in the pinna. So prophylactic antimicrobial therapy is recommended. And again, it's the same antibiotic that you would use in the acute setting, but you would use it for about a year, sometimes even longer, depending on the response of the patient. It's important to also treat the underlying risk factors so that these patients don't get a recurrent infection. Another condition that can mimic perichondritis is furunculosis. And this is inflammation of a hair follicle that can result in subcutaneous spread and cellulitis of the surrounding structures, including the pinna. The organism here that's often isolated is Staphylococcus aureus, although Pseudomonas and Proteus species have been also identified in these patients. The etiology is usually patients that scratch in their ear canal, can be allergy associated. Patients who are immunocompromised often get these type of furuncles, such as diabetics, HIV positive patients. And the presentation is usually, it's quite painful. If it's within the ear canal itself, you can have hearing loss, purulent arteria, and they often, if it has spread to the pinna, they do get tenderness over the pinna when moving it and the tracheal area. Treatment of these patients, you can use topicals, so 10% thermal glycerin paint can be used, and the antibiotic of choice here is for mild or moderate disease is second generation cephalosporin. You can use coamoxiclav or in penicillin sensitive patients, clindamycin. For patients who you pick up MRSA on, really the antibiotic of choice is driven by the sensitivities of the organism. Patients with recurrent infection, the recommendation is that they need to be decolonized, and they often are given chlorhexidine or mipiricin, and that can reduce the incidence of subsequent Staphylococcus aureus infections. The next condition that I'm also going to be looking at is relapsing polychondritis. And this is an autoimmune disorder. It's very rare, and it occurs in individuals that exhibit a cell-mediated immune response to the specific cartilage proteoglycans, and then they produce autoantibodies against the cartilage matrix, and often results in recurrent inflammation of the three types of cartilage, so mainly hyaline, elastic, and fibrous cartilage. And they often have these recurrent episodes of cartilaginous inflammation in the ear, the nose. They can often present with saddle deformities, and as well as within the tracheal cartilage. Mean age of onset for these patients is often in the 5th decade of life. There's no higher incidence in male or female, they're both equal, and there's no racial predisposition for this condition. There's no clear etiology that has yet been identified. And importantly, in this condition, 26% of patients that have this condition have some form of ear pathology. So it's quite common in patients with relapsing polychondritis. And then, in fact, the external ear, in these ear presentations, up to 88% of these ear manifestations are within the outer ear itself. So it's a high incidence within this condition. And it can be within one pinna, but it can also be bilateral, although bilateral is quite rare. And if it is within the ear canal and within the middle ear structures, you can also get associated hearing loss. It can be sensorineural or conductive hearing loss. Patients can describe tinnitus and vertigo as well. So the diagnosis of this condition is a clinical one, and it's based on the McAdam criteria. And so you require 3 out of the 6 to make the diagnosis. So that includes auricular chondritis, nasal chondritis, non-erosive seronegative inflammatory polyarthritis anywhere in the body, ocular inflammation such as uveitis, conjunctivitis, respiratory chondritis, or any audiovestibular damage. So any 3 of those 6 is good enough to make the diagnosis. The treatment for these patients are systemic corticosteroids. Anti-inflammatories can be used for pain relief, as well as colchicine. Immunosuppressive agents are also used in this condition, so sulfasalazine, methotrexate are those type of agents. And then in the last 5 years, biologicals have come into play. So anti-factor agents can also be used for these patients with quite good outcomes. So the prognosis for these patients with these newer biological agents are quite good. And then surgical intervention is really only reserved for patients who have airway collapse that require either balloon dilatation or a tracheostomy or some form of laryngotracheal reconstruction. But the mainstay of treatment for these patients is medical. So that's just a bit of a a bit on the differential diagnosis for auricular perichondritis and some conditions to think about when you are presented with a patient like this. So then going on with the perichondritis investigations, really routine blood tests are not usually indicated, but you can use it as part of a septic workup for these patients. And you would usually do a full white count, CRP. You might want to do some electrolytes, and if there is an associated abscess, do cultures. But otherwise, there's no place for blood tests for your diagnosis. And then you can consider viral PCR swabs for patients if you are concerned about a herpes zoster infection. And then if you are concerned about, for example, a buried ear piercing or any foreign body, you can do an X-ray to see if it is involved. So the medical management of these patients, antibiotic therapy is the mainstay treatment for perichondritis. And really the management pathway is dependent on the presence or absence of an abscess. So fluoroquinolones are the antibiotics of choice, such as ciprofloxacin. And you can use this either both orally and topically forms and high dose, so about 750 milligrams BD for at least 7 days. And this provides excellent staphylococcal and pseudomonal cover for these patients. Traditionally, fluoroquinolones are not really used in the pediatric population because of the fears of arthropathy, but in recent literature, the risk is quite low, and really only about 1.6% of patients in multiple studies done in 2011, there was some form of arthropathy in children. So it is a relatively safe antibiotic to use both in adults and in children. Surgical management of these patients is really just about if there is an abscess to do incision and drainage, and we do it either under a local block, or if the patient cannot tolerate that, general anesthetic. And then patients who have incision and drainage will often require packing and redressing and some form of compression bandaging to prevent reaccumulation and to allow the wound to heal without recollection. So complications, just briefly, it's really about cosmetic deformity, and it really depends on the severity of the infection and the damage to the underlying cartilage. So it's important to get prompt diagnosis and to start antibiotic therapy early in these patients, because it can lead to cartilage necrosis and cosmetic deformities known as a cauliflower ear. Symptoms usually settle in 2 to 3 days. However, it is important to tell patients that the pain can persist for up to a month if there is significant underlying cartilage necrosis. So it's important to mention this to patients, and that there is follow-up of these patients to negate any potential complications. Are there any questions this time? I don't see anything in the chat function. Let's see. Don't see any hands up. Just okay, that's good.
Thanks, Shavina. I think I just have one comment. I haven't seen a patient with perichondritis for quite a while. I mean, until this one, I must admit, in the last couple of years that are coming on frequently. The one important thing if they're presenting is to exclude diabetes. So to check the urine and maybe do a blood glucose, random blood glucose. And then the other thing, also if they're presenting with recurrent perichondritis, then just the one discerning factor is that you can often get mimickers, like I mentioned, the dermatological conditions. But the hallmark feature of the perichondritis, auricular perichondritis, is the pain. And it's not just like a little bit of pain, it's actually quite severe pain. And that kind of distinguishes that from, so immediately you can tell this is not just a cellulitis of the skin. This is actually perichondritis, which is extremely painful. And as you mentioned, the risk is that they develop a polypharmacy, and that's why we're so aggressive with our treatment. So I think, yeah, that's about it. Thanks.
Dr. Harris, is there any more comments or questions from participants?
And also, I think it's also part of the differentials. You can get tenous manifestation with TB in immunocompromised patients, and also cutaneous lymphomas can also present in a similar picture. So we also to be able to have the high risk of suspicion.
Thanks, Charles.
And I don't know, I think Scott Brown, they describe it as like a spectrum of diseases from erysipelas to frank perichondritis to carditis erosion. So I'm not sure if it's with.
That's probably changed, that sort of, but I mean, I can imagine that, if you start off with the infection of the skin of the dermis, eventually it involves the cartilage, then you've got perichondritis. But the involvement of the cartilage, the hallmark feature is really the degree of pain. Is that kind of clear? You can sometimes get, you can get an otitis externa that extends, but I mean, okay, otitis externa, you've got sort of the deep-seated pain, but the involvement of the cartilage is incredibly painful. And these patients often need like a lot of analgesia to actually resolve their pain. That's really the crux of perichondritis. Is that clear?
Yeah.
Thank you, Dr. Harris. I don't see anything on the chat function, and any hands up for any of the participants. So thank you for attending, everybody. There will be an email sent out in the next while regarding our next meeting and our next topic. So thank you for joining us this morning. Have a good weekend.